So we're going to begin at the beginning. We're going to talk about how brain metastases present, how we diagnose them, and you're going to hear lots more about prognosis throughout today, particularly when Dr. Whitfield talks and when Dr. Colasso talks at lunchtime. Just sort of a vague idea about how prognosis has changed and is changing. So, the incidence of brain metastases is rising. The brain metastases occur in about 20 to 40% of all cancer patients and up to 50% in some types of lung cancer. Brain metastases are most common in patients with lung, breast, renal cell and melanoma. And those four groups account for the vast majority of the cases who are referred to the neuro-oncology MDT and who come under our care. Less commonly are GI cancers, particularly both upper and lower GI. Occasionally we see bladder cancer. It's uncommon for ovarian cancer, endometrial or prostate cancer to spread into the brain. Although ovarian in particular, we've seen a few recently, and again I think that reflects more active treatment for the disease outside of the brain. It's estimated that the incidence of brain metastases has doubled in the past 2 decades and is rising. And there's one reference here from 2009, but actually there's quite a lot of other literature to support that. So in the past, the natural history of brain metastases was that they occurred very near the end of the illness, when systemic disease was progressing, when prognosis really was measured in a short number of months. And without treatment, the average survival was between 2 and 4 months. With palliative radiotherapy, it was always said that that could be prolonged out to 6 months. But the Quartz trial was a trial which was done in lung cancer, which again Dr. Whitfield will talk more about. But that was randomising people with lung cancer to and uncontrolled systemic disease, so progressive lung cancer and brain metastases to either radiotherapy, palliative radiotherapy to the whole brain or best supportive care. And in fact, that trial has not shown any benefit of whole brain radiotherapy. So even this area around palliation is changing. But the area which is probably changing the most is the area of people who are fit for and who would potentially benefit from active treatment with modalities, again, that we're going to talk about today, such as surgery, stereotactic radiosurgery, as well as factoring in whole brain radiotherapy. So brain metastases are occurring in fitter patients with good performance status. The brain metastases may be diagnosed before people have any symptoms. They're occurring when the extracranial disease is controlled or before people have any treatment for their primary disease at all. And again, this reflects the fact that we're giving more treatment for systemic disease and those treatments are more effective. And so people are living longer. Because they're living longer, disease has time to spread into the brain. The boundaries of what's controllable is also shifting. Again, you'll hear us talk about the fact that aggressive treatment in the brain is only of benefit if the disease in the rest of the body is controlled or controllable. But we are being more aggressive and more proactive with slightly more advanced disease than we were. And so the boundaries of what's considered controllable are shifting. Brain metastases are also occurring in patients with higher expectations of treatment. And again, I think in the past, even when I started training, there were a lot less treatment options, but also I think people, do come with much more, I want to talk about this and I want to think about having that. And all brain metastases are not the same. And again, this is a big change in the field because in the past, we've always just talked about brain metastases as one great lot. But in fact, we know that there are subgroups in breast cancer, lung cancer, melanoma who actually behave quite differently. And this is a very rapidly changing area of oncology, and there's much less nihilism and more treatment options from all disciplines, surgeons, radiotherapists, medical oncologists. So I mentioned that brain metastases can be diagnosed in asymptomatic patients, and this is a big thing. There are groups of patients who are now having screening MR brain scans, and again, that's a new thing. That didn't happen until comparatively recently. And the groups are the 4 primary tumours which are most likely to spread into the brain. So for patients with lung cancer, it's actually nice guidance to consider an MR or a CT brain scan in patients selected for treatment with curative intent. Okay, so what they're saying is, of those people with higher risk disease, stage 3 disease, so there's 4 stages of disease, stage 4 being completely metastatic, so stage 3 being sort of locally advanced primary tumour with some spread into local lymph nodes. Consider screening those people for brain metastases at the outset before you begin intensive treatment to the lung. our local practice here in Manchester is to do MR brain scans for all of those patients. And again, I'll talk about MR versus CT, but it's also mandated for most trials in that patient group in lung cancer. In melanoma, asymptomatic patients are also screened. The NICE guidance in melanoma is a bit vague. It describes NICE guidance supports brain imaging in high-risk selected patients, a high-risk resected patient. So that might be someone who, say, had a melanoma which is quite thick, maybe going down into the deeper layers of the skin, perhaps with some local lymph nodes. But it's a bit fluid, but certainly the asymptomatic patients are being screened, and they're also screened prior to clinical trials in melanoma. In renal cell cancer, interleukin-2 is a viciously toxic treatment, and they want to make sure that if they're going to go ahead and give that treatment, that people, that they're selecting the best groups to benefit, and brain mets patients may not benefit, and they're also screening trial patients. In breast cancer, it's not yet routine, but because we know that ladies who have received Herceptin have an increased chance of having their systemic disease controlled, but they also seem to have a higher chance of developing brain metastases, and the Herceptin doesn't cross the blood-brain barrier. That group are at increased risk of brain metastases, but they also do better. So although they're at higher risk of brain metastases, their outlook is better. So asymptomatic screening is a big, big issue for people. And obviously it's a big issue because as soon as brain metastases are diagnosed, there's an immediate loss of driving licence, and it has all sorts of implications in terms of insurance and all manner of things. In symptomatic patients, brain metastases can appear not infrequently as a first presentation of cancer. So people are brought to casualty, they maybe have a fit or some weakness of their arm or leg or some type of neurology, perhaps thought to be having a stroke, brought to casualty, have a scan shows brain metastases, then they have a CT thorax abdo-pelvis to look to see whether there is a primary tumour or whether there's metastatic disease anywhere else. And it's not that's a not infrequent presentation pathway, particularly in lung cancer. But we know that for people in that situation, if we're very proactive in the brain and if they have radically treatable disease, for example, in the lung, 5-year survival can be 34% in selected patients. I mean, lung cancer with brain mets, more than a third of them alive at 5 years. I mean, that's, we didn't ever talk about that in the past. Brain metastases can also develop metachronously, so sometime down the line after primary cancer treatment. So again, we're treating disease curatively, but again, we're also increasingly treating even metastatic disease with curative intent. And the commonest one there is colorectal cancer, where if colorectal cancer spreads into the liver or increasingly into the lung, people are having surgery to resect the metastases. And again, that means that in the past, people would have been overwhelmed and succumbed to liver metastases. Because the disease in the liver is controlled, they're living longer, they're going on to develop brain metastases. But also, when systemic disease remains controlled or is controllable, and again, this is what we were saying, that there are many more options now for systemic treatment than before, but a great many of them don't penetrate the blood-brain barrier. So I think for breast cancer, we're now up to about 6 or 7 potential lines of chemotherapy, which is controlling things in the lungs and in the liver and perhaps in the bones, but the brain can be more difficult to penetrate. So for all those reasons, these are all the reasons why brain metastases incidence is rising. But we do also have to remember that they can still be an end-stage event. And so for all of the very proactive things we're talking about today, there is unquestionably still a sizable group of people for whom brain metastases do occur at the end of their illness and where the management is very palliative. So presenting symptoms really depends on whereabouts the metastases are in the brain. So they can be functional deficits relating to the location in the brain. They may be seizures, as we've said. They may present with raised intracranial pressure, symptoms such as headache, vomiting, confusion or drowsiness. But I think from seeing these patients, certainly the ones we see in the stereotactic radiosurgery clinic, an awful lot of them seem to have very little by way of symptoms and almost sort of mention a bit of a twinge of a headache or something in passing. This is the brain. I'm sure you will remember your neuroanatomy, having loved it to bits. Frontal lobe controls sort of memory and personality. Parietal lobe and the motor strip, which controls movement in the arm and leg, sits just in front of the central sulcus here. And then there's 2 speech areas in the brain, Broca's area and Wernicke's area. Broca sits just there between the frontal lobe and the temporal lobe, and Wernicke is slightly further back. So if we just look at some clinical examples now. This is a lady who I saw in clinic yesterday, in fact. She has had breast cancer for a number of years, and she had some sort of slightly funny bit of unsteadiness, and that's been going back till about December, and she had a brain scan in December which actually was completely clear on the basis of that, but she had a bit of a faint, and so an MR brain scan was performed, because I think we have a low threshold of suspicion these days, and it showed this tiny little brain metastasis. So all of this is normal brain, and all you can see is this little 4mm dot here. And that's all she's got. That's an immediate loss of driving licence. So this lady came completely well, no symptoms, drove herself to the hospital, had the scan done downstairs in the department here. As soon as we see this dot, that means this lady can't drive home. She's got 2 teenage kids, mom's taxi is off the road. Big issues. This was another chap that I saw this week, in fact, who has this tumour, very neat little tumour sitting right in his motor strip. So we know where the motor strip is, because the motor strip sits quite high up near the top of the brain when we look at it. This is an axial, so MR brain scan chopped through that way, and then coronal and sagittal. But you can see it sitting very, very clearly there. The motor strip sits just there, and in the precentral gyrus, and that's sitting just right in the motor strip. He presented with weakness. So that's the right side of his brain. He presented with weakness of his left arm and leg, was thought to have had a stroke, had a scan. Again, that's the only lesion in his brain, but that's particularly difficult. One of the points that's going to be made later on today is that size doesn't matter. You're in many ways better off with a big metastasis in a less critical region of your brain, like your non-dominant frontal lobe, than you are with a small metastasis in a very critical region of the brain, because again, we're going to talk about the effects of treatment. Surgery or radiotherapy. Surgery could cause increasing weakness because of damage to that region of the brain, which could be temporary or permanent. Radiotherapy can also cause swelling, and so there is every chance that his deficits might get worse with treatment, at least in the short term. So, very difficult area of the brain, but it just demonstrates the motor strip very nicely. This is somebody who came in, so an elderly gentleman who presented again to casualty, but very sort of non-specifically, a bit unsteady, a bit slurred, a bit of a headache. Could have been infection, could have been anything really, but had a brain scan, and again it showed multiple widespread metastases. So these are just 4 example slices from his brain. There are others, and he's just got multiple. You can see the brain mets, white dots all over the place, and there are others. These are just the ones I've shown. This is someone who presented with raised intracranial pressure. So what you can see is, again, so you can already see how very different all these brain metastases look, from little tiny dots to these great big enormous cystic things. This is from a lung cancer, and this is the type of thing. You can see this mass effect in the brain. You can see the midline, which should be a nice straight line down the middle, is squashed over. You can see the ventricles, which should be nice and symmetrical and sort of butterfly shaped, again, are being squashed. And this is causing increased pressure in the brain. And so this is someone who this is the kind of picture where you get raised intracranial pressure with headaches, which are classically worse on leaning forward, or coughing or sneezing, can be associated with nausea or vomiting or visual disturbance, and sometimes with photophobia. But you wouldn't expect all of that from, for example, the first lady I showed you with the 4mm tiny metastasis. So these are just some of the ways brain metastases can present. Just a quick word about diagnosis before we get on to treatment. Diagnosis is reasonably straightforward. You do a brain scan. What type of a brain scan? If people present acutely to accident emergency or to the general medical take, they nearly always have a CT scan first, because if it's query stroke, they want to exclude, they want that CT as the investigation for stroke. If they present with a seizure, again, that's the quick screening test that can be done from casualty. But if you're more concerned sort of electively, what you really need is an MR brain scan with contrast. There's no reason to be doing CTs, and again, I'm going to show you some pictures of that. When we look at MR brain scans, the imaging appearances are rarely in doubt. Usually our neuroradiologists are pretty certain what they're looking at. The main differential would tend to be infections, and we have seen some things in the past that actually have turned out to be TB, which look for all the world like lots of little tiny mets. Occasionally, a differential diagnosis can include an abscess, but usually with more advanced MR imaging, they can work that out. But usually, the imaging is pretty conclusive. So this was just to make the point about different types. So this is an MR scan. So the MR scans that everybody's going to be talking about when Dr. Whitfield and Dr. Colaco and everybody are talking, they're going to be talking about post-contrast MR brain scans. So that's an MR brain scan acquired after an intravenous injection of contrast. And the metastasis takes up the contrast. This is the lady we looked at before with this little metastasis over here. But you can see that without the contrast, before the contrast, that's completely invisible. And the point of that scan really is to look for blood or bleeding in the brain. That's the CT, and again, we can say nothing on a CT. So post-contrast, MR brain scan with contrast is the investigation we need to be able to say anything meaningful about brain metastases at all. If someone has really multiple metastases causing lots of mass effect and they're very unwell and they're clearly coming towards the end of their life and it's very obvious on the CT, then an MR scan may not change management. But other than in that very palliative situation, really people need an MR with contrast. This is the other patient we looked at. This was the chap who presented with sort of unsteadiness, and these are his scans again. So what you can see is that's the post-contrast, but again, that's the pre-contrast. They're just invisible. You can see a bit of the dark, you can see a bit of darkness, a bit of swelling, but you certainly can't see anything that you could target there with surgery or with radiotherapy. And again, that's the CT scan. So it's just to make the point that the post-contrast MR brain scan is what we need to be able to say anything about these patients. So in summary, what we've said is that brain metastases can present at any stage of the cancer journey, not just in the terminal stages. We said that presenting symptoms can be localizing if it's affecting a particular region of functioning of the brain, but much more commonly, they're quite non-specific. We said that an MR brain scan with contrast is mandatory in patients who are being considered for any form of more active treatment. But the prognosis very much depends on the outlook and the treatment options for the extracranial disease. If you've got well-controlled early-stage disease, then your outlook overall from aggressive treatment from the brain metastases is much better than if you are someone who has already had many lines of treatment and your overall prognosis and your overall journey is nearing an end. Active treatment, including surgery, stereotactic radiosurgery and whole brain radiotherapy, can result in prolonged survival in some subgroups, and that's what we're going to spend the rest of the day talking about, and about how we manage symptoms for these patients. Thank you very much.